Hi, I'm Apurva Sharma from Mount Sinai Hospital, and I have the pleasure to introduce to Dr. James Januzzi, who is a professor of medicine at Harvard Medical School, and who is going to present the ARISE HF study today. So, welcome, Dr. Januzzi. Do you mind sharing the background? What motivated you to do this study?
Sure. Well, first of all, Dr. Sharma, thank you for having me. It's a real pleasure to speak with you and the rest of the FITs. So, ARISE HF is a study looking at a therapy that has been developed to treat something called diabetic cardiomyopathy. Diabetic cardiomyopathy is a heart muscle disease that's thought to affect about 1 in 5 people with chronic diabetes, related to the chronicity and severity of chronic hyperglycemia. The idea is that using an aldose reductase inhibitor to block the production of sorbitol in the cardiomyocytes would slow the progression of heart failure in people affected by the diagnosis.
Okay. So, would you mind sharing the results to us today?
Sure, absolutely. So, as we presented, the ARISE HF trial enrolled 700 patients, or about 700 patients with diabetic cardiomyopathy and a reduced exercise capacity as identified on cardiopulmonary exercise testing. We chose these patients because they are high risk for progression to symptomatic heart failure. We randomized them to receive placebo and 2 doses of a drug called AT001, which is an aldose reductase inhibitor, for 15 months, after which we did a second cardiopulmonary exercise test to evaluate the impact on exercise capacity. What we found was that patients treated with placebo from baseline to 15 months had a worsening of their peak VO2, so their exercise capacity worsened. Patients treated with high-dose AT001 had a stabilization with no worsening. However, the proportional difference between the two was not statistically significant. So the study overall was neutral despite the favorable findings that we see. Importantly, in a pre-specified subgroup analysis, we showed that people that were not receiving an SGLT2 inhibitor or GLP-1 receptor agonist at baseline had a very large and statistically significant benefit from being treated with AT001. So the study leaves us with more questions maybe than answers, but identifies a path forward for future studies.
So you shared with us the results. I would go more into the study now, and so going into the thick and thins, like what was it, a multi-center, international study, because now we have a major trials which have like over the world. So can you please go ahead?
Great question, especially because diabetes affects people differently depending on the region that they live in, right? So, persons with diabetes in South Asia have a different manifestation than persons with diabetes in the United States. So it was an international study. It was 62 sites globally. We enrolled around 691 exactly patients in the study, 50% women actually. So unlike many clinical trials where there's a disproportionate balance of men versus women, actually in ARISE HF, the majority were women. It was 50.4%. It's a very multiracial, multi-ethnic population. About 20% were Hispanic, with a global distribution of Caucasian, Black individuals, as well as other ethnicities. The interesting aspects of these patients included the fact that they had longstanding diabetes over 14 years typically, but by regulatory requirement, so regulatory agencies required us to make sure that we had all of the heart failure risk factors locked down really tightly. So these people had very well-controlled blood pressure. They had very well-controlled blood glucose. Their hemoglobin A1C was under 7%. You don't see that in everyday clinical practice. So this is a really unique population of patients. And so, when we look at the results and we see that there's a potential benefit from aldose reductase inhibition in these patients, we recognize that in a more general population of patients with more hyperglycemia, the benefits might have been even more noteworthy, because it turns out the way aldose reductase inhibition works is it blocks a pathway called the polyol pathway that is triggered by high glucose. So in theory, if you have patients whose sugar is very well controlled, there may not be as obvious a benefit. So when we're thinking about next steps for this clinical trial and the next steps for this drug, looking at a more representative population of persons with diabetes seems to be a very logical next step.
Wow, that was really impressive. Now, as you brought this up, so what were your inclusion and exclusion criteria that made you to get this like very controlled population?
Yeah, we wanted to really try to have as pure a population as possible to make sure that this wasn't a clinical trial of, patients with uncontrolled ischemic heart disease, right? So in order to get into the study, patients had to have diabetes, of course, and then they had to have stage B heart failure. So stage B heart failure, just to remind the viewers, is asymptomatic left ventricular dysfunction or elevated cardiac biomarkers. They could not have prior symptomatic heart failure. So these are people who've never had a diagnosis. They're not taking loop diuretics. And we excluded known ASCVD, known valvular disease, and known arrhythmia. So we tried to get as pure a population of people with heart muscle disease, presumably from diabetic cardiomyopathy.
And would you mind sharing the promising? I know you have brought this up, but the results that were most impressive for you?
Yeah, so what we see from around a year, 15 months of treatment with AT001, this aldose reductase inhibitor, we see that among individuals treated with placebo, their peak VO2 worsened. So the baseline peak VO2 was 15.7, which is terrible, right? I mean, for a population, at risk for heart failure, this is a very high risk population, but it worsened even further in the placebo treated patients, whereas those people treated with AT001, there was a stabilization with no worsening. However, the difference between the two groups did not reach statistical significance. So the primary endpoint was promising, but not significant. When we look at patients stratified on the basis of whether they did or did not use an SGLT2 inhibitor or GLP-1 receptor agonist at baseline, we found that those people not receiving an SGLT2 or GLP-1, which was 2/3, right, is a large number. And in everyday practice, persons with diabetes, still the percentage receiving these drugs is still rather small. What we found is that those people not receiving an SGLT2 or GLP-1 receptor agonist had even worse exercise loss, and after being treated with AT001, the benefits were now statistically significant. So we've identified a population of patients who clearly seem to benefit from the drug.
Mhm. Any limitation that you think is very significant in the study? Or
Thank you. Always important to think about
Yeah.
limitations. I think it's for fellows, for faculty, when you read a research study, you always have to ask, what are the limitations? The first is that this was a short study. It was only 15 months long. The second limitation is that when we look at the primary endpoint being neutral, and seeing an effect in people not taking SGLT2s or GLP-1s, you have to ask, well, shouldn't they be getting those drugs anyway? I think that's an important concession. I would say, however, that there are a large number of people who just simply can't take these drugs. Either they can't tolerate them or they can't afford them. And so identifying opportunities to reduce complications of diabetes, even if a drug like an SGLT2 inhibitor can't be given, is an important finding. Nonetheless, I think the fact that we were restricted to enrolling individuals who had very well controlled diabetes is a limitation, in the sense that diabetic cardiomyopathy occurs because of poorly controlled diabetes. And so looking at a more representative population in the future is definitely something that we hope to do.
No, I totally agree. Like, it's a very promising initial path to the next steps, I think, in the future. And thanks for sharing with us.
Thank you.
Any last line you want to say about
Thank
this?
you. I appreciate that. I mean, it's been 24 years since I was a fellow in training, but I'm, so very fond of the memories I have in training. And my advice is enjoy every minute. It doesn't get any easier, that's for sure. But, you have the opportunity to sort of see the entire sort of range of what you can do in cardiology, decide on what your future is, and really, enjoy the steps as you sort of take this journey.
Thank you. Thanks a lot, Dr. Januzzi. And if you want to see more of this, you can follow us on FITsOnTheGo on the Twitter and the YouTube channel. Thank you.